Hello, my name is Greg Basura. I'm an associate professor at the University of Michigan in the Department of Otolaryngology, Head and Neck Surgery, in the Division of Otology, Neurotology, and Lateral Skull-Base Surgery. And I'm coming to you today via this TED Talk to share with you some of the exciting things we're doing in the developing Western African country of Ghana, where we're attempting to build a long-standing medical partnership between otolaryngology physicians there in Kumasi, Ghana, with our own physicians here at the University of Michigan. Specifically, we're targeting a hospital called Komfo Teaching Hospital, or KATH. So today I want to talk about why we chose KATH Hospital, the history of it, what the needs assessment were when we first went over there in 2013, and how we established a medical partnership and some of the nuts and bolts that go into that. I'm going to highlight some of the things we're doing from a clinical and surgical training perspective that utilizes surgical simulation, talk briefly about some of our audiology research there, clinical research, and then our future going forward. So we published this article with our initial findings in 2017, and we're very proud of this because it not just provides a highlight of what we've done there, but gives an overview of what a medical partnership is, not just the typical what people think is a medical mission, dropping in, doing cases, and leaving. This really highlights and emphasizes the importance of teaching local physicians on the ground how to do cases so that they can better serve the citizens of their country. So the history of KATH Hospital, this was established in 1955. It's a teaching hospital for the medical students from Kwame Nkrumah University of Science and Technology, or KNUST. The hospital itself is a 1,200-bed facility, so very large, endorsed by the Ghanaian College of Physicians and Surgeons. Of the 41 trained otolaryngology surgeons in Ghana, 25 are currently practicing. And these folks have to serve approximately a country of 26 million people. So a pretty well overwhelming task. 9 of those physicians are in the capital city of Accra, 9 in Kumasi, where we're targeting our partnership, and the remaining are found in the remote locations throughout the country. 17 of the 25 trained physicians there are working in a hospital setting, an academic setting, like a tertiary care hospital. Others are in the regional or secondary level, and then or in the district hospitals.
Kumasi is the capital of the Ashanti region of Ghana, and it's known for its rich culture. We are surrounded by the Brong-Ahafo region, western, eastern, and the northern regions, and you have all kinds of people living in Kumasi. You can find virtually every tribe in Ghana here in Kumasi. The average majority of people work for themselves. You have traders, people who make sandals, cobblers. You have people who weave kente. They are selling to people more from outside Kumasi. People travel from the 3 regions in the northern part of Ghana, from the Brong-Ahafo, western region, eastern region, and even some of our neighboring countries.
So why did we choose this place, KATH Hospital? Well, the University of Michigan had established ties with this hospital 30 years ago through the Department of Obstetrics and Gynecology, and they found that there was a possibility to develop these long-standing partnerships with physicians to help them understand infant mortality rates at that time and maternal death. So based on that, we developed that relationship had been established by the University of Michigan. We went over there as a fact-finding tour in October of 2013 with 3 basic questions in mind from an ENT standpoint. Is there a clinical, educational, and research need in Ghana, or the region for otolaryngology head and neck surgery practice development? Secondly, if there was, is there sufficient infrastructure for us to support a high-level collaboration where we could teach and supplement their clinical and surgical training within the subdisciplines of ENT? And then lastly, is there a desire on both sides for a long-term medical partnership that would sustain them? And so what you see in Table 1 is what I mentioned earlier, is where some of the ENT physicians are located throughout the country, and you can see that most of them are in a tertiary hospital. So this is where you're going to see most of the complex patients, where you're actually training other residents. So it's very important that we train the trainers to optimize down the line. So training at KATH, there was currently at the time when we first started, there were 5 attendings at KATH Hospital. In the last 10 years, they trained 14 physicians, about 1.4 per year. 6 of those had completed fellowships and working in the teaching hospitals or tertiary centers. And the residency at KATH is a 3-year program, and I've outlined it here. Won't go into too many details, but the bottom line is that in a shortened period of time, whereas otolaryngology training in the United States is 5 years plus a fellowship, most of these folks are getting their training in less than 5 years. Year 1, they do basic ENT, head and neck exams, and some basic surgical skills. Years 2 and 3, they're doing more supplemental related disciplines like ophthalmology, neurosurgery. And then in a 2-year fellowship, they may do things like audiology or dedicated voice, head and neck cancer, or endoscopic surgery. All of these are limited, however, based on technology and training. The Ghana College of Physicians and Surgeons, and also if it's a possibility, they recommend they do some kind of post-training fellowship, which usually those are available outside the country, even outside of Africa, where most transition to Europe or other countries to obtain that training. So this speaks to the idea that there's a big need there that we can supplement. There's a niche that we can step into to augment the partnership. So what's the purpose here? Well, there's insufficient numbers of otolaryngologists practicing in Ghana to serve its population. There's a limited opportunity of Ghanaian physicians to acquire training for ENT specialties. The University of Michigan had partnered there, so we had established a base. And this medical educational partnership really is addressing skills acquisition, research within the residency program to develop the needs. So in the needs assessment we first went over, we found of all the things that they initially needed, we found that ear surgery is something that was a vital need. That they see, as you can see here from 2010 on to 2015 in this truncated list of some common otologic issues, that there's a large need. That we discovered that you see a lot of patients with draining ears, perforations of drums, chronic infections, with little or no capacity to manage these diseases. And therefore, this was one of our first target subdisciplines that we found when we went over there with. And when we spoke to the Ghanaian physicians, they found that if they had to choose amongst all the problems that they see, ear problems predominated. So when you establish the infrastructure and the basic needs, it's important when the partnership is to, you have to do an initial site visit. You have to have boots on the ground to find out what's actually going on. Investigate and triage the needs accordingly, which is what we did. Secondly, when we found that otologic care and surgical training was the primary need that they had, we then supplemented with some funding here at our own university. Because we're in a developing country, they had limited resources, therefore we use institutional and departmental grants, and we obtained some startup funding with departmental matching to acquire microscopes, drills, and otologic instruments as their first sets to take over to establish the partnership. So when we first arrived, we initially built 2 temporal bone dissection labs, simulation surgical labs with the microscopes and the drills, outfitted them with instruments. And we also outfitted the operating rooms with a whole host of otologic instruments themselves, as well as the clinic. We brought different equipment and educational materials for the clinic as well. So starting off, it's important to find out what our needs are and what our funding is, and then going into the acquisition mode. So in terms of clinical training, we needed to improve basically their binocular otologic examinations, being able to see the ear under binocular vision to not only diagnose disease, but then to follow that, pre and post-surgical. Use of micro-instruments in the clinic is paramount, and most of these physicians have never seen these micro-instruments to clean an ear, simply things like wax removal or to remove dead skin or even foreign bodies, for example. We also integrated lectures to the medical students, the residents, and the nurses by supplementing what we're showing them hands-on in the clinic with the patients, which you're seeing here lined up in the hearing assessment clinic. This is a typical day in this Ghanaian clinic where the patients are lined up all the way out to the door. We also supplement with the lectures to supplement their clinical skills. So all this was geared towards improving screening to determine surgical cases. So how do you know what is surgical, what is not surgical? What can be followed clinically or medically managed versus something that absolutely needs surgery? So we focused our understanding of audiograms, so hearing tests, of course imaging, which is also limited there in terms of CT scans and MRIs, and of course pathology, getting a timely pathology, which is also a challenge in the developing world. On the surgical side, we also found that once we've identified the surgical needs, we also had to outfit that accordingly. So equipment needs for otologic evaluation and procedures at KATH were obviously significant. They had really limited surgical ability because of limited technology and limited available instruments. So there was no dedicated operative otologic microscope. So many things, if the mastoid needed to be open for disease, it's the old hammer and gouges, chisels, to simply evacuate large disease, to exteriorize or extirpate disease, versus fine-tuned microinstruments under with an otologic drill, for example, with microinstruments under direct visualization that's binocular and microscopic. Previous procedures, again, were limited. So partnership also went beyond surgical. It went into nursing care. One of our star nurses in our department traveled with us on 6 trips now to help train the nurses about how, not only what are the instruments, but how do you care for them? Because we are only as good as the instruments we can use, and if the instruments are broken or dysfunctional, then it limits our ability to care for patients. So this was something that's not intuitive on a medical partnership, but is one of the most vital components of it if you're going to succeed. Surgical cases, again, things that we were trying to teach initially were routine otologic problems, so cerumen impactions simply, without damaging the drum or forcing an instrument through the middle ear and damaging the facial nerve or dislodging vesicular chains or causing infection or pain. Tympanic membrane perforations, managing otitis media or middle ear infections and externa or external ear infections, and cholesteatoma, a chronic disease we see on a regular basis. Managing other things like oral polyps or keloids, which is more hypertrophic scars, cysts, mastoiditis, of course, temporal bone, both soft and bony traumas. And the focus was on basic cases initially, because one of the ethical dilemmas that we faced there was that they would hold cases for us to do that were very complex, that needed our care. And so when we showed up there, some of the cases were, the pathology was too far advanced for even us to manage with what we had, even if we had the patient here in the United States. And so there was an ethical dilemma in which we had to balance selecting cases that were simpler for them to learn from, that they could extend their skill set on, but unfortunately not being able to care for those patients that had more complex disease. So these are other challenges that exist in a medical partnership that people don't necessarily are aware of until you're actually there and appreciating that. And this picture shows a patient that we operated on who had Meniere's disease, which you'll see a video on later, that ultimately needed a labyrinthectomy to cure his intractable disease. And that's actually us operating on him in the back, at the bottom there.
I was coming to the clinic. At the market square, I tried to take a taxi. Then I began feeling dizziness. Then I fell. The taxi driver and a friend brought me to the clinic.
He was on the ground. He couldn't stand up. He was so wildly dizzy that he couldn't even stand on his own 2 feet. With medical mission trips, you do more of humanitarian service where you drop in, do some surgery, see patients, which is fantastic work, but the difference here is that we're actually training the local physicians to do these cases. If it's not quite comfortable, you're not ready for it, go back to what you're comfortable with.
There's only about 10 to 20 certified otolaryngologists in a whole country of about 30 million people. Some of the physicians, in the manner they've been trained, there are certain things they don't do. One of those key areas is doing ear surgery.
Each day that the University of Michigan team is here is a learning process for me, getting better at what you are doing and then learning new things.
If you lay down?
If I lie down on this ear, I feel normal.
So John, the patient who's suffering from severe vertigo, would repeatedly come to the clinic seeking help. Local doctors here were basically limited on what they could do, but they thought, and astutely, that maybe he had a disease called Meniere's disease, which is an inner ear fluid problem.
My hope for this collaboration is that we acquire more skill to be able to pass on to people that we train.
I learn a lot from practicing physicians here in Ghana. Their diagnostic skills are quite amazing. We've become, in the United States anyway, much more dependent on technology in order to make a diagnosis. I've learned how to be a better diagnostician, a little less reliant on technology.
Was the tinnitus really loud? He would go up and down? Because he had no usable hearing. He was having these severe attacks causing falls. We made a decision that the best thing for him was a surgical ablation of the inner ear. And then hopefully once he gets through the surgery and recovers, he won't have this problem anymore and he can get back to his life.
I'm just praying that God come and intervene so that after the surgery I'll be able to get back to work.
Surgery went as expected. We had a great team composed of partially U of M and the KATH hospital folks. He's recovering nicely. It was incredibly satisfying to be able to intervene on a problem that has derailed someone's life. Also, it's equally satisfying is to train the doctors here that would eventually see these patients so that they can do that for themselves, you know, for the people here in Ghana. So incredibly satisfying. So one of the hallmarks of the success we've had there is implementing surgical simulation. As you can imagine, we can't have, even with our residents here, we can't have them operating and doing certain cases on live humans. So obviously honing your skills in surgical simulation situations is very important. So there you can see in the top picture that we created, that's one of the temporal bone drilling stations we established there in KATH, where it's outfitted with a microscope, a drill, a bone, a cup there at the bottom to hold the temporal bone to practice drilling, doing these techniques in the temporal bone. But beyond that, we did things like with a sinus head and neck dissection course and some head and neck anatomy. But this is an essential component for training and developing as an independent skilled provider. Other things that we did was we created simulation ear canals to place ear tubes by simply taking a syringe, cutting off a glove off of a finger, stretching it over that, and then working down the barrel of the syringe, simulating the ear canal, and the rubber glove simulating the drum. You can practice making incisions, inserting tubes. So these are innovative, real simple, but yet elegant ways to implement training in a pseudo-realistic environment that is imperative for this ongoing training. So one of the other things that we did that goes beyond medical and surgical was outreach for audiology. Audiology and ENT obviously hand in hand. It's important to understand that a lot of these folks, especially the children, that we don't really have a good handle on the amount of hearing loss that currently exists in the country. Not just to identify it, but to manage it. So there's an average of almost 2,000 patients are seen at the Hearing Assessment Center annually. Most are adults that are older, most are adults, but half of them are, almost half, are younger than 18. Audiology testing is limited to pure tone and bone conduction threshold measures there, and there's no newborn screenings. And of course, pediatricians are occasionally referring high-risk infants and toddlers for hearing assessments, but there's no true understanding about what the rates are. So one of the things that when we went over there, we discussed with them, and the cornerstone of working in a tertiary care center is you have to not just be delivering high-end clinical and surgical care, but you also have to be advancing the field. You have to understand what your clinical epidemiology is to a certain degree. So we partnered with the KNUST School of Public Health, which is a very sophisticated group who has Gates Foundation funding that partners with other U.S. centers to come up with a pediatric hearing loss study within urban and peri-urban Ghana using portable measures. So using a shoebox audiometer and a Little Ears questionnaire, we developed an IRB and we went out into the field to begin to screen children in the Kumasi community. The idea was, can we create a portable platform where we can identify these children who can't get access to the clinic, identify them in hearing loss at early stages in their life so they can get managed at an earlier time. We also screened cleft lip and palate children in the oral maxillofacial surgery clinic, and we published that data. And interestingly, one of the attendings who you saw in the video, she actually was so excited about this research, she actually went on to do her master's in public health in this project. So that was very exciting to us that she is going to pursue and continue this work, writing for grants, and begin to establish an outreach program to screen for pediatric hearing loss. So what's the future of this? Well, we completed 6 trips in Ghana. We're developing some performance metrics there to understand and work toward independence. The attendings are beginning to do more cases on their own, relying less on us. We successfully wrote and obtained grants for clinical research in the pediatric hearing loss, and that will continue. The cleft lip and palate clinic continues to grow, which is where you'll see a lot of hearing loss and conductive losses. But one thing that I realized, and I won't talk about it here, but in the future talks to come, is that like residents and trainees here in the United States, we all go on to fellowships if we're going to do advanced medical practice. And with ear surgery, it requires a fellowship. So what I've learned is they're no different, and in fact, they're further behind us because their training coming out of 4 to potentially 5 years, they're not as sophisticated. They don't have the skill sets because of just simply where the location that they're at and all the constraints that they have. So as such, I'm pursuing now developing an otology fellowship in Alexandria, Egypt, where one African physician can be selected to go and spend a dedicated year in Egypt, acquiring more advanced cranial-based and ear surgery techniques that they would take back to their home country and then apply. So that will be launching in 2021. The first fellow will likely be coming from northern Ghana in the Tamale region, and he'll come to Alexandria for a year. He'll learn, advance his skills there, and then go back home to northern Ghana and ideally care for his patients in a more thorough, comprehensive way and handle more sophisticated problems there. And then training reciprocity is having our residents coming back and forth from U of M, which they're now going there, to train the trainers, train the other residents.
We're in Ghana because we really want to improve the training of physicians in performing ear surgery as well as performing other types of surgery in the head and neck area.
It is not only Michigan coming to Ghana to do the cases. They are teaching us how to do it.
There's actually exchange of ideas and education that will go both ways, not just from Michigan to KATH.
We've been coming for about 2 years now, and even during that 2 years, we're just beginning to ramp up to a point where we can really make a difference.
There you go. Put about 4 ties in there.
The young people we meet here, I'm quite certain that if we can help them get where they want to be, there's no doubt in my mind that they're going to go out and help other people in the same way.
Hands-on experience that not only allow them to do surgeries better for themselves, but also to be able to take that same skill set and impart it upon their trainees.
In the next 5 years, we hope that at least we'll be able to build enough capacity in Kumasi to train people in otolaryngology.
The main goal is really to help the young future physicians and leaders in Ghana, but also actually at the University of Michigan, be better people, better physicians in the end.
Good.
So it wouldn't be complete if I didn't acknowledge some folks here. Dr. Mark Prince is the chairman of our department and really is the spearhead of this, along with Jeff Moyer. David Brown, a pediatric otolaryngologist, is also involved early. Joe Kolars, who is here in the departmental or in the hospital leadership, was one of the key stakeholders who actually helped us with funding initially. Bruce Edwards, you see on the far left there, is one of our main audiologists. He's now retired. And then Bianca Waller is our scrub nurse, who was absolutely paramount in her contribution to the nursing staff there and training them. So, as they say in Ghana, is Madasi, which means thank you, and I appreciate your attention today. There is a link at the bottom here for additional articles about our partnership there that you can read about. Thank you very much.